When looking at drugs that act on the reproductive system, there are other drugs that are available to treat the symptoms of postmenopause, particularly the risk of osteoporotic fractures. So we'll look at the SERMs, the selective estrogen receptor modulators. If estrogen was spelt without the O, the acronym would be SERM, a SERM, plural SERMs. We'll also look at bisphosphonates in the treatment of osteoporosis, and they are used in conjunction with SERMs to treat postmenopausal symptoms, such as that increased risk of osteoporotic fractures. First of all, the selective estrogen receptor modulators. As their name of the drug class suggests, they are tissue-specific. They work on receptors for estrogen that are found in bone tissue, and they affect the metabolic processes here. This makes them a good alternative to hormone replacement therapy, where they will have fewer adverse effects systemically. There are also phytoestrogen combinations that are found. These are plant compounds that have estrogenic activity. There may also be phytoestrogens that have other actions as well as that estrogenic activity. They are used pharmacologically, and they are classified as SERMs, as selective estrogen receptor modulators. Other drugs used in the treatment of osteoporosis include hormone replacement therapy, because it does prevent that postmenopausal bone loss. We will summarise some of the findings of the clinical trials and the use of hormone replacement therapy as a prophylaxis for osteoporosis. There are also nutritional therapies, calcium and magnesium supplements, vitamin supplements, and so on. Calcitonin is another treatment therapy, but we will look at the bisphosphonates and the selective estrogen receptor modulators before summarising hormone replacement therapy. The bisphosphonates include alendronate. The bisphosphonates are potent inhibitors of osteoclasts, particularly their metabolic processes. This prevents these osteoclasts from resorbing bone. This results in an increased bone mineral density, and long-term this decreases the fracture rate. Bisphosphonates directly bind to the bone hydroxyapatite crystals. They become part of the mineralized bone structure. With that bisphosphonate incorporated into the bone structure, that bone structure becomes resistant to the enzymatic degradation by the osteoclasts. The estimated half-life of a bisphosphonate is similar to that of normal bone, 1 to 10 years. It's important to note that these bisphosphonates alter both the function of the osteoclasts in terms of their enzymes and the structure of these osteoclasts when they bind to the bisphosphonate bone surface. This is what inhibits that bone resorption. Furthermore, the bisphosphonates work quite extensively through the bone structure and quite deeply through the bone structure at preventing that osteoclastic erosion. Bisphosphonates are also indicated in Paget's disease and in the osteoporosis that is caused from long-term corticosteroid treatment, as well as indicated for treating postmenopausal osteoporosis. Clinical trials have been done on alendronate, and there have been some positive benefits, quite dramatic benefits in reducing the risk of fractures, and once again reducing a variety of fractures, vertebral fractures, hip fractures and wrist fractures, where the reduction in risk was a 50% reduction. As far as adverse effects, bisphosphonates are generally well tolerated, though as you will see, there are some gastrointestinal effects. They have been associated with dyspepsia, nausea, vomiting, esophageal irritation, gastritis, abdominal pain and diarrhea. We'll look at the esophageal and stomach effects in a little more detail. It's seen that the severe erosive esophagitis and ulceration are due to people who haven't taken the alendronate correctly. So it comes down to patient education, making sure that the person on this bisphosphonate therapy takes the alendronate with a full glass of water, remains upright for 30 minutes after administration of the alendronate, and make sure that that patient does not take any other food or drugs or beverages during that 30 minutes. Other adverse effects associated with bisphosphonates: etidronate was one of the earlier bisphosphonates, and it became associated with osteomalacia. It actually was reducing bone formation as well as reducing the bone resorption, and so was not used. Bisphosphonates have also been associated with hypocalcemia, rash, musculoskeletal pain and arthralgias, and headaches. So we'll have a look at that hypocalcemia in a little more detail. If a person already had hypocalcemia, bisphosphonates would be contraindicated or used with caution. As you can guess, they would also be used with caution in people who had esophageal abnormalities. In addition, people who have severe renal insufficiency, they would be used with caution, or gastrointestinal diseases. Bisphosphonates are used with caution in people who are pregnant and lactating. There have been some animal studies that produced some abnormal findings, but in the clinical trials, there has not been a duplication of this in humans. The SERMs, the best example is raloxifene, have a mechanism of action by being estrogenic or anti-estrogenic. So they are either estrogen agonists or estrogen antagonists. These drugs, like raloxifene, have been shown to decrease bone resorption and increase bone mineral density. In addition, the SERMs, particularly raloxifene, have been shown to have favourable effects on cardiovascular disease and do not increase the risk of breast cancer or endometrial cancer, and this is in contrast to hormone replacement therapy. So their indications: used for postmenopausal osteoporosis as a prophylactic, that is a preventative treatment. They are an alternative to hormone replacement therapy. We've said that they might not increase the risk of breast cancer, and the clinical trials have actually showed that they may in fact reduce the risk of breast cancer. Raloxifene has been studied in this regard and may be as effective as tamoxifen, but raloxifene is not yet registered for this indication. Once again, raloxifene may reduce the risk of cardiovascular events in women at risk, but it is not yet registered for this indication either. But clinical trials are showing some good results. SERMs show some adverse effects. The common ones are hot flushes and leg cramps. The hot flushes are their estrogenic or anti-estrogenic actions on vasomotor activity, and this usually subsides after 6 months. Some of the serious adverse effects of the selective estrogen receptor modulators are that they lead to retinal vascular occlusion. Precautions: used with caution in people who have altered lipid metabolism or hepatic dysfunction. We said they're an alternative to hormone replacement therapy. They would not be used concurrently with estrogen therapy. This is polypharmacy that would not make sense. Taking an anti-estrogen and taking concurrent estrogen therapy, that clearly needs some rationalising. SERMs are used with precaution in people who show an increased risk of thromboembolism, similar to hormone replacement therapy. We'll talk about that one in a little more detail. And they are not indicated for women who are premenopausal, therefore experiencing their own endogenous estrogens or perhaps taking an oral contraceptive pill. Contraindications: if a person has an active history of thromboembolic events, and certainly for some people who even just show a history of thromboembolic events, they would be contraindicated. So this is their estrogenic properties leading to that increased risk of thromboembolic events. SERMs are not used in lactation and pregnancy because of their effects on bone and bone structure. They are not used, of course, in a person who has shown hypersensitivity to a selective estrogen receptor modulator such as raloxifene. So hormone replacement therapy as a prophylaxis for osteoporosis, it used to be one of the mainstays. Controversial data has led to patients and doctors questioning its use. There was increased risk of certain cancers, and it was proposed to help with cardiovascular events, but was shown to have an increased risk. It was also shown that estrogen therapy would have to be initiated within 5 years of menopause and should be continued for a period of 10 years. In terms of this or longer, it was suggested that to reduce osteoporotic fractures, it would be most beneficial if that therapy was maintained for 10 to 20 years post-menopause. So we'll look at that time frame. This is perhaps putting the woman at the age of 75, where the benefits of estrogen therapy and effects on osteoporosis would rapidly decline if the drug was discontinued after that 20 years, roughly 75 years of age. It is known that hip fractures occur later in life. These hip fractures are one of the greatest causes of morbidity and mortality and osteoporotic fractures in people who are, say, 75 years or older. And this is the very time that that hormone replacement therapy would be ceased. So perhaps to get the greatest benefit, the woman might need to take that hormone replacement therapy indefinitely to reduce the incidence of fractures. But remember that this will increase the risk of negative effects of hormone replacement therapy. We talked about the increased risk of certain cancers. For women in that age bracket, breast cancer particularly would be a problem. So if a woman and her doctor were going to consider this, it would be the lowest effective dose of estrogen. 625 micrograms is still a very high estrogen dose, but it is thought that that 625 micrograms, or that's the equivalent to 0.625 milligrams of the estrogen, would be beneficial. This estrogen could be one of the synthetic equivalents, or it could be the conjugated estrogen, which is of a horse origin, conjugated equine estrogen. So in summary, osteoporotic fractures, looking at a prophylactic treatment, that would be alendronate and other bisphosphonates. For a person who is postmenopausal, it would be a SERM with the alendronate or other bisphosphonate. And the good example of the SERM, raloxifene, which may in the future be used for other indications other than osteoporotic fractures and prophylaxis. It may be used in future in preventing breast cancer. And of course, the mainstay of preventing osteoporotic fractures estrogen replacement therapy. It was the estrogen replacement therapy that was associated with all the high risks of cardiovascular events and cancers, so perhaps an estrogen combined with a progestogen as a prophylaxis for osteoporosis.